At 19, Case Atencio had a heart attack, a genetic condition, nothing he could have prevented, nothing he could have planned for. The medical bills arrived faster than the recovery. He fought debt collectors for 6 years. He declared bankruptcy at 25. Now, 30. His credit score is still damaged. He is still paying. He did not fail the system. The system was not designed to catch him. It was designed to bill him. In 1980, U.S. per-person healthcare spending was $943 a year. In 2024, it was $13,265. That is a 1,306% increase. Over the same period, general inflation rose 281%. Healthcare did not just outpace inflation, it left it behind. Where did the money go? When a third party pays the bill, the patient has no reason to ask the price. When the patient has no reason to ask, the provider has no incentive to compete. When there is no price competition, prices move in one direction. The actual transaction happens between the insurer and the provider, negotiated in private, settled weeks after the visit. The patient receives an incomprehensible document that bears no relationship to anything they agreed to pay. Worker contributions toward family health insurance premiums rose 308% between 1999 and 2024. Earnings rose 119% over the same period. The worker is paying more for the coverage and more for the care and getting less of both. The administrative layer consumes roughly 25 cents of every healthcare dollar before a single clinical decision is made. It is true that populations are aging. Treatments that did not exist in 1980 exist today, and they are expensive. Healthcare is labor-intensive in ways that limit productivity gains. These pressures exist in every system, regardless of how it is financed. The question is not whether healthcare becomes more expensive than manufactured goods. The question is why some systems become dramatically more expensive than others. The market is already running a live experiment. A cash pay MRI at an independent imaging center commonly runs $300 to $600. Insurer-negotiated charges for the same scan can be several times higher. Remove the intermediary, and the price falls dramatically. A hip replacement in the United States costs $30,000 to $50,000 through insurance. The same procedure in Thailand or Malaysia costs $10,000 to $15,000, paid directly, including flights and recovery. Patients are not flying to Bangkok because the care is inferior. They are flying because the price signal there has not been destroyed. The direct primary care model is the domestic version of the same vote. A flat monthly membership, no insurance billing, no administrative overhead, no surprise bills. This market is growing at 24.5% annually. Doctors see fewer patients, spend more time per patient. Patients pay less and receive more. When the intermediary is removed, both sides of the transaction benefit. The same monetary conditions that erode purchasing power elsewhere also sustain this distortion. Sound money does not eliminate every cost pressure. The aging population is real. The cost of genuine medical innovation is real. But the 1,306% increase in per-person spending since 1980 cannot be explained by an aging population alone. It is what happens when the price signal is removed and the monetary system funds the distortion indefinitely. Casey had his heart attack at 19. He declared bankruptcy at 25. He did not make bad decisions. He faced a bill that bore no relationship to any price he had agreed to, and the debt followed him for over a decade. Prices are how an economy communicates. When patients cannot see them, providers cannot compete on them, and the system loses its ability to discover what care is actually worth. The price nobody sees is the price everybody pays. This is the Cantillon Letter, monetary truth. Understand it first. Subscribe and visit us at cantillonletter.substack.com.